Hey, Jose Almeida here on behalf of IVC community. Another case for you from last Friday. Of course, those of you who've been listening, Fridays is when I tend to go to the hospital and do the bigger cases. My practice is mostly office-based venous surgery, but on Fridays, I'll do these difficult stent cases at the hospital. Usually they're post-thrombotic. And lately, we just had a run of occluded stents, some mine, some from other places. And this particular kid, 40 years old from Key West, turned out to have antiphospholipid syndrome, and his stent has been occluded for 10 years. And the poor guy, typical post-thrombotic syndrome symptoms, heavy, painful leg with lipodermatosclerosis in the ankle. And he wanted something done, so he came up to see me. And this case took a while, as many of them do. I think we're in there 5 hours, 5 to 6 hours. We do these with general anesthesia and a Foley, and we end up using a bunch of equipment, which is why this is not really suitable for the office. Number one, conscious sedation, 5 hours, they're not going to make it. And two, the cost of the equipment that we pull off the shelf to do these, not going to happen in an office. You'll go bankrupt. So with that, let me share my screen. So a 40-year-old white male from Key West, right iliac vein stent placed 10 years ago, occluded soon thereafter, and was found with a hematology workup to have antiphospholipid syndrome. Well, as we know, this is one of the worst thrombophilia one can have. And he's currently on Coumadin, which in the modern era, Coumadin is not a common drug anymore, but that's the one that blocks multiple factors. And this antiphospholipid syndrome, we've had a couple, and the other ones we've had are either on fondoparinox or on double dose. Actually, I've got two other ones. This is the third. One is on fondoparinox, double dose, recommended by the hematologist in getting antiphospholipid therapy, this new immunotherapy. The other one on double dose Eliquis. He's been open for a while now, and this is my third one. And the hematologist has had him on Coumadin. So we'll put him on Lovenox for a month afterwards and then reconvert him to Coumadin. So let's move on here. In the office, my ultrasound tech is very good at these. We found an occluded iliac vein stent. You actually see one wall stent here, the other one here. So it's telescoped on one onto the other, as was commonly done with wall stents. You can see the step off of the stents. So if we're going to fast forward, when we use the device, RevCore can go up, but you don't want to have this metal basket coming back the other way because you're going to catch on these and have a problem. And I'll show you that. So that's pre-op ultrasound. And then we found that his common iliac vein was actually open and had collaterals around the external iliac vein stent occlusion. And his inflow was via the profunda, which is the only reason I decided to do this case. If the femoral vein is down, as long as there's a profunda, that's usually adequate outflow. And these can be tricky, as we'll show you. Initial injection, so we like to get access in the mid thigh. In this case, we had to go in the upper thigh. The femoral vein's occluded, so he had one compressible vein. Is either a duplicated femoral vein or a collateral, but we got into the duplication that was open and upsized to an 11 French sheath. And this is our injection where we don't see the bony landmarks well, but this is the pelvis, the occluded external iliac stent here. Here's that collateral we saw on ultrasound. Let me show you right here. Maybe if we stop it, let me just stop it for you and pause it right there. Here you see the common iliac filling. There we go. Common iliac filling. Here's the collateral. Here's the occluded stent. And here's a really junky looking common femoral vein. So that's what we're dealing with. I show this because we typically will put in the 11, then telescope in an 8 French by 25 centimeters. Why 8? Because an IVUS catheter goes through an 8. And then usually we'll use a Tri-4 system or some sheath with a support catheter and wire and just kind of work our way up proximally. So as we go from access to target, which is the vena cava, we build columnar support as we telescope longer and longer devices. So this is 11 centimeters long, 25 centimeters long, and 55 centimeters long. And of course, the wire is an exchange length wire. 035 angle glide. Here we are already upsizing to a 12 French sheath because just trying to get more support from below. and trying to get friction out of the system with a balloon. That's as far as we're getting our wire. There's the upper sheath that you can see, but we're having trouble navigating this area. Actually, this is from above, sorry. And I'll show you this in a second. This sheath is from above. We can't get through this segment. This is our wire from below, and we're trying to just do balloon angioplasty, get friction out of the system so we can upsize devices. Now, there's a device that I just found out about called the B-back that has a sharp. You can throw a needle out, kind of like a mini system, but you can throw the needle out. It works with an 018 system, and you can use it for sharp recanalization. It goes through a sheath. So we were using that, and we still weren't able to get through this thing. So we went to the more aggressive Roche Ashita needle. And this thing, you got to be super careful. The gantry's got to be going back and forth because even though you look like you're in an AP, you rotate to an orthogonal view and this needle can be out. So basically every centimeter or so, we're rotating the gantry, making sure we're inside. And oftentimes we'll just do some puff venograms just to make sure that we're still intraluminal. Here's the collaterals filling, so we're confident that we're intraluminal. So obviously you got to be very careful with these things because they're very aggressive. It's a TIPS catheter. So this is a metal harpoon coming out of a sheath. So that's the part doing the work. So they're safe inside stents as long as you're careful going up. So we were struggling a lot from below. So we came internal jugular access through the cava and tried to see if we could we knew the common iliac vein was open. So we wanted to see if we could recanalize the stent from above. This is a collateral and had a hard time from above also. So we just went back down and kept working from below. And eventually we got a 14 French sheath here. This is from above. 14 French. Through this, we put the Roche Ashita. Through this, the B-back. So the B-back now had metal support. And we took the back end of a V18 wire, the sharp end, and little by little, we were able to just slowly work our way up. So what you're seeing here is the wire at the end of the stent. We're about to enter the cava. This took us probably a couple hours just going back and forth with the gantry, inching our way up with the Roche Ashita, the B-back, the wire, back and forth. We did exit the stent several times, creating false channels. So you just got to be patient and keep working it. Several times the Roche Ashita was through the stent wall. We didn't see it in one view, and after we rotated it, we saw it. So then you got to back out, rotate the needle. It's a lot of patience, but we did get it up here. And then we returned back to our telescope system. Here you see the 5 French, the 8 French, and the 11 below. And now we finally made it to the cava. And we're doing puffinography to show that we're in the vena cava right there. It's our injection. So after a few hours, we can finally, now that we cross, because once you cross, that's the whole key. Now it's just really stretching things out and using the rev core. And if you have to reline with the stent, you have to reline. So now we're through. Showed you that already. Again, the telescope system. Now from above, we're going to put this Protrieve funnel. You open the funnel, and as you're working from below, here it is. You always have to have a straight wire in front of you, always under direct visualization, because you can do something bad in the heart if you're curled in here. So the wire straight, and you're just moving that gantry again, following the device over the wire, right? Here's a curve, so we got a little, that's when we just stop, get the tension, get that wire straightened out. There's a wire straightened out. Now we keep going. But you don't want to do anything stupid like that with a curved wire. You have to be visualizing everything. You can see how you can have a problem there in the heart, which we did not, thankfully. So we got the device down safely and deployed the funnel, you see here. And then our wire that's in the cava from below, we'll throw it through the funnel and come out the neck and grab it with a hemostat so we have a body floss. And that'll be with an Amplatz wire that we exchanged, so a good heavy working wire. Prior to the Triforce, we're going to create a tract within the stent, and that's usually with an 8 French 8mm balloon. So that's what we're doing here, creating a tract before we hit the rev core. You can also send the IVUS up and look inside the funnel, like we're doing right there. You can see inside the funnel. and make sure the funnel's fully deployed so no embolic material goes around the funnel. So we were good there. Now with the RevCore going up again, here's that stent overlap. So we've got to be careful to only RevCore here below the overlap. And if you want, you could go this way through the overlap, but you're not going to go backwards because you'll catch the RevCore on the stent struts. This is what the RevCore looks like, an aggressive metal basket. You can actuate it using this wheel, and it'll tell you down here how big, how dilated the basket gets. It can get up to the 4 setting, I think, is 16 millimeters. So you can really scrape out of up to 20 millimeters. There we go. All right, so we were using it lower levels not to damage the stent. I've been waiting for a device like this for a long time because prior to this, all you could do is do hyperballoon inflation and get as much fibrotic material to the wall, and then usually have to reline it. And you leave the fibrotic material there, and then when you reline it, you're losing luminal gain because you cannot remove the thrombotic material. But now this removes it. So here's on the 1.5 setting, you see it deployed, not much. So we're going to slowly work it to where the basket is completely scraping the stent wall without catching the stent struts. So you just do this little by little, increasing it as you go back and forth. And all this embolic material will go north, so the funnel will catch it. That's what it looks like after some material's been removed. That's what it looks like fully deployed. Again, here's the overlap of the old stents, the bottom one and the top one. So now we're scrubbing the bottom. There was one moment where I went this way. That's why I say one direction only. You can only go north if you're going to do one motion, but you don't want to bring it down or the RevCore will catch right there on that old stent. You can see how it's not fully opposed to the wall. Let me stop it there. You can see how the stent is hanging out in the lumen here. So if you come back this way, the basket will grab, this is braided alloy, these strands will get in there. I've done it before is why I say it, and you can cause some problems. So just try and avoid it like we did here. And now we see that at the bottom of the stent, again, we're being aggressive. We did cause some fraying of the braided wall stent. It's not a problem, but just a note that these things are aggressive. This is, we went up to the funnel and suctioned out the funnel. You do that every few passes with the RevCore to remove the embolic debris. And then you can, it's a syringe up top, you suck out the blood with the funnel, and you can after you filter the blood of the debris, you can reinfuse blood to the patient. So it minimizes the blood loss. It's a nice system. I don't know if I explained it well, but so after a few passes, we still don't have contrast running well, so we have to keep working. And this ended up being, we knew we were probably going to have to reline the stent. Unfortunately, I don't have the IVUS images. They didn't make it to the packs. But that basically showed a clotted stent, and every time we brought the RevCore up and down, we were removing material, we started to see more and more lumen. But we did have some residual thrombus on the walls. And of course, we had that area of stent overlap that was causing a stenosis and problematic. So now we thought we got as much material out as we were ballooning so that when we reline with the new stent, we're going to be stent on stent. And we're not, again, the problem that we have leaving fibrous material in the old stent, when you reline it, you're going to lose lumen. So that's what we're doing here. We used, in this case, 16 by 140 Zilvervena. All the stents work, all the new Zilvervena, Abre, Bonovo, they all work fine. We just happened that the rep was in the room and had everything with him, so we just used that one. So we realigned it. You can see how we have some work to do here with the balloon to get that stent on stent. So post-dilate with balloons, with a 16 millimeter balloon, up and down in the usual fashion. And then we do our run. Now we've got a patent stent. We still have that collateral up top, which is okay. You can see it's not perfect looking, but we have some residual material here in the common femoral vein extending into the profunda. So in the old days, we would definitely, the new stent comes down to about here. In the old days, we would just extend the stent and then try not to jail the profunda and tack this stuff up. Now we have a VenaCore device that we're going to put in here and try and just debride this area of fibrotic material. So here's the VenaCore, similar thing device to the RevCore. It is a little different, and I'll show you. So here we're going to fully expand it in the common femoral vein. Here's our new stent, and now we're actuating the basket. And in this case, you don't really rev up and down the vein, north and south. Turn the wheel to get a rotational movement and see if the baskets can grab fibrous material. A bad videographer here, we'll come back to it. And then you do that, rotate it, and snatch it, which I'll show you. So how does that work? So you can see the basket's a little different than the rev core. Some sawtooth looking blades. So you turn the wheel rotationally, and then with this device, you squeeze the handle. It'll collapse the working basket and grab the fibrous material, and then you remove it from the patient. And that's what that one looks like. You can see the sawtooth blades a little bit on here. And after 5 hours, this is our final run. You see, we still had a little material left, but the contrast is running up. So I didn't really want to extend a new stent in this area. And we thought that with good anticoagulation post-op, that this will remodel. At least I hope it will. But you can see much better than when we started. So, and just to show you all the equipment that we use, micropuncture access from below and above, multiple sheaths, 8 French, 11, 12, 14, the angled ancil sheath that we use from above, cannulate the common iliac vein from above, multiple wires, usually the 035 angle glide wire, the V18 we use through that B-back device, Benson wires, what I like to use from above to get into the cava. Cross-lead wire has been my favorite to go through stents. It'll get a loop and go through occluded stents. We used 3 of them and it would not go up. Even the Advantage wire is 035 soldered onto a Lunderquist, very good wire. None of the wires would go up the stent. So that's how we had to get aggressive. What ended up working was a B-back inside the Roshishita. Then the Rev Core, Vena Core, Protrieve, and the filter system from Inari. The good thing here, they offer this as a package. So the hospital's not billed piecemeal. So if you need the Vena Core, it's already included. Just bring out the device. I thought that's clever. Bunch of balloons we use, from Conquest balloons to Atlas balloons. I don't know how many of them we use, many. And then the ones over Vena Stent. So I don't know how many thousands of dollars this is, but it's a lot. And I don't want that expense in the office. So we do these in the hospital. So I think overall, pretty good case. Again, takes a while under fluoro. Did it with our 3rd-year vascular resident, Fritz Chow, who did a nice job. University of Miami Hospital, great staff, great equipment. He went home the same day. That was on Friday. I'm dictating this now on a Sunday, so we'll see him in the office this week for suture removal and ultrasound. Hopefully that thing will be open. We'll have him on 100 BID of enoxaparin for a month, and then we'll probably go back to the Coumadin. I'd like to go to Eliquis, but if the hematologist feels comfortable with Coumadin, we'll do that. All right, signing out, Jose Almeida for IBC Community. Hope to see you in Miami in April for IBC, April 24th to 26th. Thank you.